Surgery at UCSF. And my talk this morning is to talk about testing for thyroid cancer, but really what we're going to talk about is nodules today, which is probably the more common scenario that people are encountering in day-to-day practice and sort of how to navigate that in this molecular age. So I do have some disclosures. Although none of these are relevant to the talk today. Okay, so I know that Dr. Bana gave an introduction to thyroid cancer in general with a focus on the pediatric side. So it is the most common cancer of women in the U.S., and the incidence has been rising, and as many of you know, a lot of that is probably due to just detection bias, that we're doing more ultrasounds, more attention is being paid to the thyroid exam, and people are feeling more, and it's just more in people's minds. So despite this rising incidence, survival has been pretty flat. So the upshot of that is that perhaps there's more disease being noticed, but these are small nodules, small cancers that are unlikely to affect survival. Yet the more aggressive cancers, that has been sort of around at a steady rate. So it's not that there's necessarily an epidemic of thyroid cancer occurring, but so it's on us to decide who actually needs treatment, to what extent do we need treatment, and how aggressive do we need to be. So just an overview again, I know that it's been discussed, but papillary cancer is the most common, with follicular second, and these two have very good to excellent prognoses. And then there's a variant of follicular called Hürthle cell, which may have a little bit more resistance to some of our treatments. And then we have medullary, which can be familial, and we all know the syndromes that are associated with that. And then we get to the group that is truly aggressive. So these are the ones that are truly driving survival in our patients. So poorly differentiated or anaplastic. Oftentimes these patients present with very aggressive disease, and it's quite obvious that this is the situation with them. And they're the ones who don't do well, despite all our treatments. So interestingly, part of this epidemic, so to speak, is that thyroid nodules are really common. So if we were to just put ultrasounds on people, and about 60% of people have some sort of thyroid nodule. And of course, we're not doing biopsies on 60% of the U.S., but theoretically, if you had an ultrasound, you're at the course, and you realize you have a nodule, many people think, well, I should have that biopsy because I want to know what it is. So the guidelines for the ATA came out in 2015 on how to help manage these, and this is sort of the landmark study that everyone can look at and look at the different recommendations. But one of the things was to actually don't biopsy the things less than a centimeter, unless, of course, this has certain features or if it's near anatomically important structures like the recurrent nerve. But the idea is that we want to put the brakes a little bit on all the enthusiasm we have for all the thyroid nodules that are out there. So this is out of that paper, and the idea is that for patients who have a normal TSH, that you rely on thyroid ultrasound, but then based on the size and the suspicion pattern of the ultrasound itself, you can offer an FNA, but typically if it's over a centimeter. So this is kind of a key factor here. And then based on the size as it increases and that the suspicion pattern sort of rises, then you would go ahead and do that needle biopsy. So they came up with the Bethesda system as well, as you probably all know, 1 to 6, to try to force the pathologist into, rather than just using descriptive terms that may not mean as much to the practicing clinician, to a bucket. And then you say, okay, based on this bucket, I can now do this. And so they have the different categories here that we'll go through. And then in addition, oops, uh-oh. Sorry. Can we go back one slide? Okay. The other way. Okay, thanks. So the American College of Radiology also came up with their ultrasound guided TIRAD. So this is not to be confused with the Bethesda classification, but this is really just to understand which of these ultrasound features that we just talked about are actually concerning. So again, there's a point system, and you have to grade it based on the different features on the ultrasound, and then you hit enough points, reach a certain size, and then you should perform the biopsy. So again, nice guidelines for who actually deserves a biopsy in this day and age. So these are the categories, and they actually did modify them a bit in 2023. Just to get rid of this, some of the terminology so that it's classic of these 6 ideas. So non-diagnostic, benign, atypia of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant. So when you look at the malignancy rates, it's generally quite high if you look across many studies. And so obviously if it's malignant, if they come back with a class 6, chances are it's cancer, then you can behave accordingly. Interestingly, suspicious for malignancy, the risk of cancer is about 75%. I think it depends a little bit on where you practice, but I'd say that it's rare for me to have a level 5 that isn't cancer. Most of the times they are. And then class 3 and 4 are the ones that are sort of indeterminate, and then 2 is benign. So the issue is that, and I'll explain this to patients before we get the biopsy so that they know what this means, is that this box here, this 3 to 4, it doesn't mean that it was a bad sample. It doesn't mean that we got to do it again. It doesn't mean that there's some technical component to it. But this actually represents about 15 to 30% of all biopsies are going to end up in this class 3 to 4 range, which then you have to try to decide, well, what's my risk of malignancy here? Okay, so fast forward now to the modern age where we have a little bit better tests than just looking at the cells themselves and are they pink and purple, do they have inclusions and things like that might be obvious, but all the indeterminate nodules that require architecture, that require the ability to sort of tell how these cells are arranged, which you are not going to get on a needle biopsy. So, we can look at cytopathology, histopathology, which you have been. They can do stains to try to look for certain markers, which have not been shown to be that helpful necessarily. But then we start to get to things like DNA, RNA, microRNA, circulating proteins and factors. And so all these things are now things that are accessible to us. The technology is there that we can actually implement this in patients. So it's important to understand now what are these molecular changes, because this gets into the test. So it's sort of like when you order a sodium and you get your sodium back, you kind of know what that means. But now there's going to be this multiple of different markers that may show up. And it actually is sort of important to understand what those mean, because if you're the one ordering the test and you're going to make decisions, there's going to be a summary, but sometimes reading between the lines is always important. Sort of when you read a pathology report, you look at the summary, but then you kind of got to look back at it, or a radiology report. You have to kind of read between the lines a little bit. So just in broad strokes, there are separate molecular profiles, and they can be BRAF-driven or RAS-like. BRAF is more often associated with papillary cancers. RAS is more associated with follicular cancers or neoplasms. Okay, so again, I have no disclosures. These are the three that are kind of probably largest in the market at the moment. The Afirma, ThyroSeq, and then ThyroGen or ThyroMir. And the idea is that they use different technologies or different fingerprints to try to best classify these indeterminate nodules. So we're now focusing on the class 3 to 4 nodules, those in that indeterminate range, to help differentiate them into who needs surgery and who does not. So the Afirma test uses RNA, it's RNA-based. The ThyroSeq, the third version, is a mix of DNA and RNA signatures. And ThyroGen and ThyroMir uses DNA and RNA as well as microRNA. So they're each using kind of a different platform that's proprietary to try to understand what these nodules might be doing. So a little bit of a busy slide, but this is kind of the upshot, is that when we look at sensitivity, specificity, positive predictive value, negative predictive value, they're quite high. And the take-home message is that obviously it depends. This first box is the input. So for example, if you live in a place where 99% of your indeterminate nodules end up being cancer, it's going to affect the range of this test, right? It's going to seem like it's either better or worse on the negative or positive predictive side. So there's some degree of statistics you have to kind of grasp. But the idea is that these are all kind of about the same, roughly. So these are very good at generally saying that things are benign. They're generally less good at saying, we're pretty sure this is cancer. So most of these end up being kind of rule-out tests. So it's reassuring when you get a negative study that you can tell the patient, we can watch this, it's safe. On the other hand, if it does prove to be cancer, that's the line that has been creeping up. So in early studies, that might have been 20% risk. So it changes from 5 to 10% to 20%, but then you have a 97% chance that you can say it's okay. But slowly with these addition of markers, what's happening is as you look at this bar, these blue bars, this is the positive predictive value, the chance that if the test says it's positive, that it actually is cancer. That has now crept up in the past 5 to 10 years because that test has gotten more sophisticated. Okay, so I have to introduce NIFT-P if anyone's not aware of this, but NIFT-P is this non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This is the best acronym they could come up with. And the idea here is this is actually an example of it, is that they may very well look like follicular or papillary-type cancers, but they do not invade. So they don't invade the capsule. There's no vascular invasion. There's no capsule, lymphatic invasion. And so the idea behind this NIFT-P is that these, when you pull them out of the sets of patients who were found to have cancer, they were generally lumped in the cancer diagnosis, but you pull them out, they did remarkably well. They never developed anything further, and they did great. So the pathologists and the thyroid community has decided this is actually not cancer, probably. On the other hand, all those things I just mentioned, like capsular invasion, vascular invasion, you can't get that on cytology. You have to look at the entire thing, and this is one of the things about defining this feature, this subtype, so you have to look at it in order to say what's going on. Now, that being said, they haven't got rid of this notion that maybe this is a precancer or that if you left it long enough, it turns into cancer. And we don't necessarily know that enough, but most people suspect that it is sort of a precancer condition. So that you have to do something. You can't just necessarily leave NIFT-P alone. On the other hand, when you take it out and you talk to the patient, you're like, look, this is precancer, you're done. We've essentially cured it, even more so than papillary cancer. Okay, so what is built into this is that NIFT-P in all these studies, when we look at the positive predictive value, negative predictive value, NIFT-P is included in that. So because it was not necessarily separated out as a different category. So in this review, what they did was they looked at the difference or the decrease or what contribution did NIFT-P have in the Bethesda classification. So you can see here that particularly in this 3 to 4 category, they had a fair amount of contribution, and certainly for the suspicious. But the idea is that if you subtracted this out, the final risk of malignancy for class 3 or 4 is 16 to 23% for those indeterminate nodules. Okay, so why is that important? So if you look at the types of mutations, again, this is just the DNA-based types of things that might be happening, and it's a little bit of promoter issues. But these are the different things that might make up a class 3 to 4 diagnosis. And NIFT-P is right here. And you can see here that there's a fair amount of molecular overlap. So a lot of these things like NRAS, HRAS, KRAS, PTEN, so again, follicular type markers, and then the theta fusions and PAX8, and even the ETV6. So the idea is that this is why it's hard. This is why the molecular signature gets kind of crossed over, is because NIFT-P does have these molecular features that would identify it potentially as cancer, even though when you look at it histologically, it isn't. And so, until we get better markers that really define NIFT-P, it'll always get kind of bucketed in potentially with the markers. So, okay, keep that in your mind. So I'm going to go through a couple of slides on Afirma and Thyroid simply because those are the ones that I feel like around here at least are most used. But over time, we talked about how the positive predictive value has improved. And this is sort of a slide from the company website. But that the previous version, the GEC, again, was very good at saying it was benign, then very few people ended up being malignant. If you said it was suspicious, it was about only 40% of these people actually had cancer. So you were operating on 60% of this sort of positive group or suspicious group that turned out not to have cancer. So over time, what has happened is the benign group has remained good, and with the newer version of this GSC, the suspicious group, the percent of those people who you operate on for suspicious Afirma test is now starting to decrease. The truly benign people are starting to decrease. So the test is getting better at correctly predicting who actually needs surgery. And basically, this sort of goes into some of the different subsites like Hürthle cell that you gain quite a bit. So they've found new markers that really identify Hürthle cell carcinoma, and they've incorporated that into the test itself. And then, busy slide, but essentially the idea is that here, 2/3 of the tests that are benign actually are benign. And then of this group, you're essentially reducing your operative rate by about 70%. So only about 30% of the people who end up in this indeterminate bucket will need surgery. And then again, 2/3 of those will probably be benign, and then about half or so will be cancerous. Half and half. So likewise with Thyroid, again, this is formerly just a DNA-based panel, but now it's gone up to DNA plus RNA. But you can see here the improvement in sensitivity over time, and then the group that actually is sort of inappropriately managed based on the test has gone down considerably. So this is the current panel, which is the Thyroid version 3. And this is a test a study where they looked at both Thyroid and Afirma, compared them, and the idea is that of the negative group, very few of them end up having cancer or developing cancer. And then within the positive group, those patients who end up with a test and end up undergoing surgery, the large majority of them are now tilted towards actually having cancer. The same is true of the Afirma group. Okay, so this is probably projecting okay, but what does a test look like when it comes back to you? So on an Afirma test, they sort of simplify it and give you this summary, and it's a little blurry, sorry, but this basically says benign. It's green, easy to read. They're fine. So when they end up with this orange or suspicious of risk of malignancy, and they actually will identify the actual errors for you. So in this case, it's a V600E translocation in BRAF. That, if you kind of know the nuts and bolts behind it, you go, hey, that's suspicious for papillary, but it can cross over with other things. And so they'll actually give you a risk profile generally. And here they're saying risk of malignancy is 50%. So in this patient, they probably need surgery. But within that, you have to understand that some of those people are actually going to be benign. So this is not necessarily a 100% test, even though it may seem like that to the patient because it's positive. You have to explain this to them that it still means that actually probably 50% of the time it's not going to be positive. Okay, so this is a ThyroSeq example, and I had a patient like this very similarly. And this is where actually understanding the rules of the road or kind of what's going into the test helps. So this test was also negative, so similar to that last Afirma test where I said, hey, we're not worried about this. But notice here they probably have cancer or NIFT-P. So they will throw that in there from time to time because they're basically saying none of those markers actually matched. So neither NIFT-P nor cancer. When they have a positive test, it actually depends on the mutational load of what they have. They will sometimes put probability of cancer, or sometimes they'll say probability of cancer or NIFT-P. Because remember, NIFT-P overlaps with particularly those follicular subtypes. So again, it's very high here. And then if you look at the mutations, actually what's driving this is this BRAF, which probably means this is a papillary type cancer. So this is probably, I don't want to say real, but true, and they actually put this at 99%. Because that mutation is so specific for papillary cancer that it's unlikely for this to not be cancer. They will then sometimes look at these mutations, so TERT and NRAS, which tend to beget a much more aggressive phenotype. Again, they're going to say, this is positive, we're worried this is cancer. And so, again, rather than just saying 20%, which is the way the old reports would read, they can now say, this is 90%, we're pretty sure this is bad. And these particular mutations are quite aggressive. So sometimes they'll actually put in these things like, because of molecular signature of high-risk cancer, total thyroidectomy may be considered for appropriately selected patients. So the idea that they're signaling to you is that we're really worried about this one. So if there are any features that might drive you towards doing a total, you should probably consider that in this patient based on these mutations. If it were a follicular situation where they're worried about NIFT-P or that, they are not going to say those things. They'll say, maybe do a hemithyroidectomy, it's up to you, but this is kind of what we're thinking. Okay, so this is kind of the outline, again, from the ThyroSeq website of what they will do. And so, again, they'll say cancer or NIFT-P, depending on the type of mutation, so Hürthle cell signature, RAS-like, negative, or BRAF-like, or positive, you can see that based on that molecular signature, they can tell you different things with different degrees of certainty. So I think this is why explaining this to the patient or reading that report kind of more carefully is important, because you can counsel the patient on these risks. Even though it's still nebulous, unless you're in this scenario where not all positives are the same, if you understand this part. Okay, and similar for the Afirma, it's a little less granular here, but the idea is that for the 3 to 4, do the Afirma test. You can say if it's benign, and again, this group, you're quite certain that's going to be benign. If it's suspicious, they actually have another test, which we're not going to talk about today, which talks about the actual mutations and then putting it sort of more specifically into a risk of malignancy. So these are more for class 5, 6 nodules. They're pretty sure they're cancerous, but you want to get a sense of how aggressive it might be. There's another test for that as well that's coming out. Or it's out, but it's, I'd say more data is being gathered about it. So cost effectiveness is something that comes up. It's really hard to define, actually, because you can look at it quality of life years. You can think about like the complications that might occur from hypoparathyroidism or recurrent nerve injury and try to bundle all this. You can bundle in all the follow-up ultrasounds that they need in the future. If you leave half the lobe, that maybe if you took it all, you didn't have to do that. You can talk about being on Synthroid forever. What are the downsides to that? And just the cost of the medication or going back and forth to the doctor to adjust these and all the lab tests. So it really depends on what you put into that model to say, is this actually cost effective? The cost of these tests, as far as I can tell, is somewhere around maybe $1,500 to $4,000, depending on where you live and kind of the milieu. These are covered by insurance, so that typically is not the issue. But the idea here is that if you went into a scenario where every indeterminate case you went in for, at least did a thyroid lobectomy, and then sort of marched that out into who needed a total down the road and kind of did the math there, that would be about $38,000 for every correct diagnosis. If you have these screening methods, so this is ThyroSeq and this is the Afirma test, then it drops it by over half. And this is trying to account for all those things that we just talked about to build into that model. But you can see where it can get a little fuzzy depending on which study included how many things, or like if you take a day off of work, how much is that worth? But the idea, though, is that less than $1,000 is probably quite effective. And I think at the very least, most of us, as on the end of it, as you're practicing, when you think about as a patient, you're like, okay, do I need to operate or not? You may not be thinking about this cost effectiveness, but you're actually thinking, I don't want to injure this patient inappropriately for something that comes back benign. I'd feel pretty bad about that. And I don't want to miss a cancer that we're just sitting on for some time that grows. So I think in most scenarios when this is built into your system, most of us would go, I think I would want that information. If you were the patient, I think you'd want that information too. So here at UCSF, we've been using this. And what's a little bit challenging is that you do have to sort of build it into your pathway so that when you get the FNA, if it's 3-4, do you send them back or not? Our pathologists here will actually save a sample if they think it's going to be class 4. They'll store it in the correct media and we happen to use ThyroSeq here, but no matter what it is, there's kits. They can set it aside, put it in the refrigerator, and if it comes back class 3-4, then they just automatically send it. So if you can develop that relationship with your pathologist, if you find that, or your radiologist, if you find that this is really helpful, these are things that can be built into your workflow. So in conclusion, it's easier in a way, this workup, because we have guidelines on what to biopsy and when. We have the molecular test to say when should we be doing this and who needs surgery, and we understand those limitations. And then they are going to keep improving. So every little signature that comes out sort of will bump us up a little bit closer and closer to truth. And so that's kind of nice, but it's important to keep up, and this is kind of the state of how things are at the moment. So thanks for your attention. This is our team, where we work. I appreciate it. Thank you.